Hi, everyone. I am Sylvia Soltis. I'm the Pro Bono Director at Legal Aid DC. I'm joined today by my colleague, Andrew Patterson, Senior Counsel in Legal Aid's Public Benefits Unit. We're here again for the Medicare Part D project, and I'm incredibly grateful for your help. Legal Aid DC could not do this work without your help. So thank you for making sure that our clients are in the right plans for the coming year. I'm going to have Andrew kick us off with the substantive updates for the coming year, and then from there we'll loop back around to talk about important deadlines and the process for Legal Aid DC. Andrew, all yours.
Thank you so much, Sylvia. And I just also want to say thank you to everyone for participating again in the Medicare Part D project for this next year. We still help a lot of people, so we're excited to be doing this again. So this is going to be sort of like I did last year. It's going to be a relatively short presentation just on the updates and changes in the Medicare Part D plans for Washington, D.C. for 2026. We're going to talk about changes to Medicare Part D, updated cost sharing and co-payments for 2026. We're going to talk about the standalone plans for 2026 and low-income subsidy standalone plans for 2026, a couple of other changes. And then, like I did last year, I'm also going to do just a quick overview of Medicare Advantage because we are continuing to see a fair number of folks getting into these Medicare Advantage plans. So for 2026, there will be 10 overall Medicare Part D plans for Washington, D.C. That's a decrease from 13 or 14 last year. And there will only be two zero premium plans for low-income Medicare enrollees. That's going to be the Humana Basic RX plan and I can't see that, the WellCare Classic plan for 2026, and that represents a decrease from three plans in 2025. A couple of other plans are going to be changing their name. These are not low income subsidy or zero premium plans, so I doubt very much that very many people will be enrolling in these. But on the off chance that someone is enrolled in this plan and they have received information about the new plan for 2026 and it carries this new plan name, that's why. A handful of plans usually change their name every year, and this year two of them are doing so. And then a handful of plans, including one zero premium plan, is not going to be offered in 2026. So the Clear Spring Health Value RX plan will not be offered in 2026. If anyone is enrolled in that plan right now, then they should be auto-enrolled in one of the two zero premium plans that will exist for 2026. And additionally, a handful of other plans are just going to stop operating in Washington, D.C. in 2026 as well. The rest of these plans are not zero premium plans. So again, I don't know that it should affect our client population all that strongly. But again, sometimes people do find their ways into these plans that have a premium if they have a sort of complicated or lengthy drug list. Some of those higher cost plans can be the only option that will cover what they need. This is the updated cost sharing, some of it that we expect to go into effect for 2026. So the Medicare Part B premium is projected to increase from $185, which is what it is for 2025, up to $206.50 for 2026. When I put this together late last week, that was still officially a projection, but I think usually the projection has been pretty close to or sort of right on the money. So that's what we expect to see, or we expect to see the Part B premium around that amount for 2026. So there will be an increase. The Medicare Part D deductible is increasing from $590 to $615 for 2026. The Medicare Part D benchmark premium amount is actually going down. The benchmark premium for Washington, D.C. is how plans determine whether they are going to be zero premium. If they are a non-sanctioned plan and if their premium is below this benchmark, then it is a zero premium plan for anyone with the low income subsidy. So it's actually going down for next year. But the reality is that there will still only be two of those low income subsidy plans that have a $0 premium next year. Most of these, of course, charges should not be charges that our client population has to pay. If a client is enrolled in the Medicare Part D low income subsidy, then they are not responsible for that Part D deductible, and they should not be liable for the Medicare Part D copay. Additionally, people who are enrolled in the low income subsidy in Washington, D.C. should also have QMB, the Qualified Medicare Beneficiary Program, and that should cover their Medicare Part B premium. So if folks are being charged anything, if they're having their Part B premium withheld, if they are being charged a monthly premium for their Medicare Part D coverage, then that's definitely, a red flag, and that can be an opportunity to reach out to your legal aid mentor because we may be able to, at legal aid internally, help them get their QMB sorted out. And the good news is when someone gets their QMB sorted out, that sort of automatically gets their low income subsidy sorted out. But we have seen a couple of instances of people who are technically enrolled in QMB, but still having their Medicare Part B premium withheld. That's usually as a result of some kind of confusion between the DC Department of Human Services and Social Security. We are usually able to get that fixed pretty easily. But if someone is not enrolled in one of these programs and they should be, then we can also offer advice, or in some cases, more beyond advice assistance to make sure people are in the cost sharing assistance programs that they should be in. Additionally, there will be a few or some small increases in the copays that the low-income subsidy Medicare Part D population in DC pays for their drugs. So the cost-sharing assistance that I mentioned on the previous slide, all of that should be covered by QIMBY and the low-income subsidy. But even for folks who are in the QIMBY and low-income subsidy, they do have limited copays that they have to pay at the pharmacy. Folks without the low income subsidy will generally have to pay a percentage of the cost of their medication, as I think most of the pro bono attorneys who are part of this project know. So these strictly limited copays, although they can add up if someone has a long prescription drug list, they do tend to save our clients a lot of money. And I'm sorry, this should read copays for 2025 and 2026. Just pretend that says 2026, effective January 1st. But for people who are in the low income subsidy and full dual Medicaid, so folks who have Medicare and full Medicaid, not just QIMBY, but full Medicaid, their copays for generic medication should be $1.60 in 2026, and for name brands, it should be $4.90. So if folks are paying more than that, or if the analysis suggests that they would pay more than that with one of the low income subsidy plans, it probably means that that drug is not covered. And then likewise, for folks who don't have full Medicaid but still qualify for QMB and who are in the low income subsidy, they will have to pay $5.10 for generics and $12.65 for name brand drugs. And one thing I will point out is that these are maximum amounts. A lot of plans, if people are taking generic drugs, the copays may be lower than these maximum amounts. For some individual medications, there may be lower amounts. So we just sometimes you will see lower amounts than this. That doesn't necessarily mean that anything is wrong. But if you're seeing a copay in someone's analysis that is higher than these amounts, then that may be an issue, and you can talk to your mentor about that. The donut hole, which was eliminated last year, is still eliminated, thankfully, but that often doesn't affect our low-income subsidy clients because the donut hole has been filled for that population for quite a long time. And again, the out-of-pocket cap is going to be $2,100 for 2026. That means essentially that people may hit that catastrophic coverage limit sooner. And I think the real world impact for our clients is that if people are paying these maximum amounts for copays, then those can go down once someone's total drug costs reach that catastrophic coverage level. So sometimes in the analysis, you'll see these copay amounts for maybe a few months, but then once the catastrophic coverage is hit, those copay amounts may go down in the analysis. So I'm going to talk just a little bit now again about Medicare Advantage, because as I said in the beginning, we do continue to see a fair amount of Medicare Advantage plans uh, recruiting people in Medicare, and a fair number of our clients getting enrolled in them. These are private, sorry for the pop-ups. These are private Medicare plans that essentially take over someone's Medicare Part A and Part B. And so when that happens, one of the key things about a Medicare Advantage plan is that in addition to containing a Medicare Part D drug formulary, they also have their own networks of providers and hospitals that are in network. So if someone is in regular Medicare and they get enrolled in a Medicare Advantage plan, there is no guarantee that the doctors they currently see in regular Medicare will participate with that Medicare Advantage plan. For that reason, we have often been very reluctant to sort of advise people amongst the different Medicare Advantage plans because there's a lot more that goes into that analysis beyond the prescription drug benefit. There is, what doctors are in network, what doctors are not in network, and we don't really have the resources to do that level of analysis for every plan for every person. Um, and then sometimes, I guess not always, but sometimes getting out of a Medicare Advantage plan can also be a little bit risky just because that same concern applies. If someone moves from one Medicare Advantage plan to another, there's no guarantee that the doctors that are in network with their current Advantage plan will be able to participate or will participate with any of the other Medicare Advantage plans. So if folks are in a Medicare Advantage plan, I do think that we can check to see if their medications are covered or if it looks like they will be covered. But you should talk to your mentor in that situation if anything comes up, because it can be a little bit more complicated to get someone out of a Medicare Advantage plan than it is to just switch them from one standalone Medicare Part D plan to another. Um, Talking a little bit more about Medicare Advantage, there is the same open enrollment for Medicare Advantage as there is for Medicare Part D, October 15th to December 7th every year. Um, as I was just saying, through Medicare.gov, we can usually tell at the very least if the medications that people are taking right now will be covered by their Medicare Advantage plan. So if someone is in a Medicare Advantage plan, then at the very least we can see if their medications will be covered, and if so, then we can advise them that their medications should be okay. But we again want to be very careful about advising them about other aspects of that coverage. If someone does want to quit their Medicare Advantage plan and return to regular Medicare Part D, then we could assist them in selecting a standalone Part D plan. Again, I don't think we would want to make any representations about other aspects of that coverage, whether doctors in their Medicare Advantage plan would accept regular Medicare. I think most of them tend to, but we can't know that for sure on an individual basis. But if someone does want to get out of their Medicare Advantage plan and get back into regular Medicare Part D, then we can help them with that as long as they're aware of those potential complications. And when we enroll them in a Medicare Part D plan during the open enrollment, that will automatically end their Medicare Advantage coverage for the following year. But as I say in the very bottom of this slide, if someone's in a Medicare Advantage plan and they want to get out, then we definitely want to encourage you to have a conversation, a more detailed conversation with your mentor about the advice that we should be giving in that situation. And with that, I think that is my last slide. So I will stop sharing and I will turn it back over to Sylvia to wrap up with some deadlines. Thank you all.
Great, thanks, Andrew. Just a quick reminders for everybody, our referral schedule, we are sending out the referrals by October 24th, and all analyses and submissions are due by November 21st. You'll be able to access, just like in the past, your clients' Part D materials via Dropbox. We'll put everything in there, your forms, your templates, and subfolders for each of your prospective clients. As Andrew said a couple of times, if you have substantive questions, reach out to your mentor. We're here to help. I will have copied them on your referral email so you know who they are. I encourage you to reach out to your clients within the first 2 weeks after you've received the referral. It is very easy to lose sight of that November 21st internal deadline for legal aid DC. We'd like to wrap everything up before Thanksgiving. So we are comfortably ahead of the December 7th deadline. Following items need to be uploaded to Dropbox. Your copy of your closing letter that you've mailed your client, your intake and consent form for each client, your documents for plan comparison and analysis for each client, drug list for each client, and enrollment confirmation if it's applicable. Please seek approval from your mentor before changing any client plans. You all have done this before, so I am confident you will do it beautifully as usual. I'm really grateful to everybody who is joining us again for this Medicare Part D season, and just want to say thanks from everyone here at Legal Aid.